such a way that we'll start with methodology, then subsequently introduction, other parts will go step by step. All will be interlinked with each other. So with this brief introduction, I request Dr. Apurva to pitch in and take over from here.
Thank you, sir. So very good evening, everyone, and thank you, sir, for opening that session. So after the success of webinar series in 2024-25 on systematic review and meta-analysis, this year, on behalf of Journal of Psychiatric Spectrum of IPS-KC, we are coming up with the online series called Wednesday Scholarly on how to write a manuscript. Now, in the 3 years of our residency, we mostly spend our time on learning psychiatry due to our less exposure during MBBS, doing OPD, taking cases in wards, doing emergency duties, department academics. In that, we are given a Herculean task of doing a critique of an already published article. Along with that, there is thesis and the NMC mandates of paper, poster, and publication. Now, in the middle of all of this, let's go back and ask ourselves that did we then, or for the PGs now, did we really know how to write an article for journal? I don't think I knew back then. So to guide us through the tough task of reading and writing the manuscript, for this webinar series, we have our senior consultants, teachers of teachers, hand-holding us on how to write a manuscript. So for the first session, we have Dr. Ravi Philip, who will be guiding us and giving us insights on how to write the methodology section of the manuscript.
Can we request President to...
Yes, sir. Yes, sir. I will come to that. Yes, sir. I think Dr. Ravi Philip has joined. Yes, sir has joined. Okay, wonderful. Thank you, sir. So before going on to the session, I would first request Dr. Anil, sir, Dr. Anil Nagaraj, the president of IPS-KC IPS Karnataka chapter, to give the opening remarks for this webinar series.
Hi, all. Good evening. I'm audible?
Yes, sir.
Yeah, finally I could join through some tweaking the account. Anyway, good evening and welcome you all for this Wednesday Scholarly. This is a well-thought initiative of IPS-KC and precisely by the Journal Committee of IPS-KC headed by our Editor-in-Chief, Dr. Vijay Kumar, and well coordinated by Dr. Ravindra and Dr. Apurva. So this is the third in our Wednesday Scholarly webinar series. First was in the year 23-24, was on research methods, and then 24-25 on how to read an article, and this one is on how to write a paper. So all this is, I don't know, I joined in the middle. So possibly this is keeping in view our postgraduates and kindle their research interest. And hopefully to make the PGs passionate in research. Obviously, this is also for all the passionate faculty researchers, and the plan in pipeline is more such activities from the Journal Committee, which includes the peer review training program. And we are pleased to have seasoned researchers today as our resource persons, Dr. Philip Rajkumar, and also as a moderator, Dr. Samiksha Sahu. Again, I welcome you all, and without wasting much of our time, I request the moderator, Dr. Sahu, to take over and have a pleasant experience through the session, all of you. Thank you.
Thank you, sir. It's an honor to be here among such esteemed colleagues. And as Dr. Apurva rightly said, when we were all students and we were struggling with our manuscripts, we never knew how to write a methodology. And nowadays, when we open and flip through the pages of any journal, the first thing we see after the title is how to write the methodology. So what was the method used? How did they collect the sample? And that is how we decide the credibility of an article. So when I was sharing about this webinar today across a lot of WhatsApp groups, we have these young psychiatry groups and all. So a lot of buzz already was there regarding Dr. Ravi sir. So somebody was telling me that Dr. Ravi sir has a savant memory, and during his Niman's round days, he used to amaze the teachers also over there. So it is an absolute pleasure, and I to welcome you, sir, as you doesn't need any formal introduction, but still for all of us who doesn't know the exact details about Sir, Sir is an alumni of NIMHANS, and currently he is a faculty at JIPMER, Puducherry from 2010. Sir is a professor over there. His areas of interest include psychopharmacology, comorbidity in psychiatric disorders, and studies of the correlates of mental health and mental health service delivery at cross-national level. He's a member of the editorial board of several journals in the field of psychiatry, including BMC Psychiatry, the Journal of Psychosomatic Research, and Brain and Behavior. He has also published over 170 papers in peer-reviewed journals to date, which includes 136 indexed in PubMed and Medline. So with Sir's credit and without further ado, we extend a hearty welcome to you, Sir, from all of us. And please share your slides. Thank you.
Thank you very much, ma'am. Gives me immense pleasure to be here with you. And, before I start, I would like to thank you for the kind introduction. Now, after you all hear an introduction like that, probably what I might say might come as a bit of an anticlimax, but let me try my best. Let us see. So what we're going to do now is we're just going to basically talk about how to write the methodology section of a paper. And a topic like this, if you really were to want to do it justice, you would need to sit and do a workshop for 1 or 2 days. But, let's see what we can do with a time of 30 minutes and we'll take it from there. I'm afraid that, maybe inspired by the fact that my son also has homework at school, I'm also going to give you a bit of homework this time. And, not that you have to do it and come and get it graded by me, but it's a kind of a self-directed learning, because adult learning doesn't necessarily proceed by spoon feeding or by rote learning. It's rather a question of learning how to do. First, somebody shows you how to do it and then you do it yourself. So let's start. So if we look at the basic scientific process, the process that is followed in any, branch of science, not necessarily medicine, we start either with some observations that we make in nature, or in our case on our patients, or with some theory that we have. We formulate a hypothesis or a set of hypotheses based on this, and then we have to design and conduct or carry out an experiment. And based on the analysis of the experimental results and their interpretation, we either conclude that our hypothesis was correct and can be accepted, or that it has to be rejected. Now, if we look at the basic structure of a research paper, I'm sure this is something that all of you are familiar with. All of you are told, write the introduction, write the methodology, or sometimes, they say write materials and methods. The two are synonymous. Write the results and write the discussion, or sometimes they use the acronym IMRAD. I'm not sure how you want to pronounce it. Is it IMRAD? Is it IMRAD? Is it IMRAD? But let's not be too radical about it. Let's move on to seeing how the two sort of line up. So if you look at the parts of a paper, when you're writing a review, either an original research article or a systematic review, the introduction would basically take part of this basic observations or theories and the formulation of the hypothesis. The methodology basically covers all the details of the experiment that you're going to do. And the description of the results, the interpretation of the results comes in the results and discussion. Now, the reason I've put this in a little bigger box or, in a slightly bigger font is because this forms the heart of the whole biomedical or research enterprise. Without doing experiments, there's no way in which we can expand our knowledge. Another way of understanding this would be to say, what would happen if I were to just cut this out? I have a paper that just has some observations, theories, hypotheses, and some interpretations. What I would be left with would be either a review paper or a theoretical paper. There would be nothing original coming out of it. So if we really want, to advance medical science forward, either in a small way or in a big way, there has to be experiments, and experiments need methodology. Now, what is the purpose of a methodology section? The methodology section basically does 4 things. It tells you how the research was done. It tells you why it was done, what was the rationale for each procedure. Like if you say, I used this scale to measure this symptom, why did you pick that scale? What were you trying to measure with it? Is the scale meant or designed to measure that? What materials were used? What were the scales you used? What were the tests you used? What were the, laboratory procedures or imaging procedures that you used? And how were the results analyzed? In other words, when we look at the methodology section, we should be able to comment on a few things. One is we should be able to comment, as ma'am pointed out in her introduction, on the validity of the study. So did the study really measure what it was meant to? And can we take these results and apply them to settings other than the one where our study was originally conducted? Second, are the results credible? Sometimes it's very obvious that a study is not credible. So if a person says, I was doing a study to measure coping skills, and the only scale that they've used is a scale to measure anxiety, then the results are not credible. Even if everything else is correct, you cannot use a scale that is used to measure anxiety to assess coping skills. And it should allow for replicability. That's a big word. Even I have trouble pronouncing it sometimes. What it means is that if somebody else wants to replicate the study, if somebody else wants to do the same study in their institute or in their country or in their setting, would they have enough information from your paper to be able to replicate it, to do it all over again? So there are certain components of the methodology section. The first and foremost, the methodology section has to mention the study design. It has to give due coverage of ethical clearance and other related issues. It has to tell you who the study was done on. In other words, who were the study subjects or what was the study sample. It has to tell you what was done to that study, to that sample, whether any intervention was done for them or whether any assessments were done for them, whether any biological markers were measured in them. It has to tell you the actual process. From the time people were recruited for the study till the time they exited the study, what was the workflow? What was the procedure that was followed? And in the end, it has to tell you how the data that you collected from your study is going to be analyzed. So these 6 components are the bare minimum that have to be there in the methodology section of any paper, no matter what paper you're writing, unless, as I said, it's an editorial or a theory paper. What are the qualities of a good methodology section? When somebody is peer reviewing your paper or when an editor is doing that first check to say, should I send this paper for peer review? What do they look for? So basically what they're looking for is everything explained in clear language? That's fluency. Are all key details included? In other words, those 6 things that I talked about in the last slide, are all of them covered in the manuscript that is submitted? Is it precise? Are we avoiding irrelevant details or extra details? Are details that should be left in the introduction or, the discussion section accidentally being put over here? Or is it written in a very focused and precise manner? And finally, is it objective? Are you just letting the methods speak for themselves? Or are you bringing in your own opinion or conjecture or theory, which should not appear in the methods section? Methods has to be purely objective. One way of looking at it, a somewhat homely way, but one that would be very familiar to all of us is to think of a good methodology section as being like a good recipe. A recipe does not tell you, take this spoon, put it into this vessel, stir it 25 times. It doesn't tell you that. But at the same time, it gives you all the essential information without any extra details or without omitting any key ingredient, with which anyone else who has some cooking talent or some cooking skill should be able to cook the same thing. So in other words, given some basic minimum level of research competency or training or infrastructure, a researcher should be able to cook the same dish with your study, even without access to your full dissertation or to your full study protocol, if you have written the methodology section correctly, if you have written it properly. That is the quality of a good methodology section. So what do reviewers expect? When we come to a certain stage in our career, we end up doing more reviewing than writing. So, I'll tell you what we expect. Methodological errors account for 3 of the 10 most common reasons for rejection of a manuscript. Somebody has actually done studies on the reasons why papers get rejected in biomedical research. And it was found that of the 10 top reasons, 3 of them were due to rejection of a manuscript, were due to methodological errors. And even if the study design is correct and the study has been done well, if that particular section has not been written well, the paper will either be sent back to you, rejected, or you will be asked to make major revisions. This is somewhat like the clinical adage that if you haven't written it, it hasn't been done. You might have sat with a patient all night and given some care to him or her. But if you haven't documented that in the case sheet, nobody knows what you really did with the patient. Same way, you might have done a perfect study. You might be an excellent researcher, an excellent statistician, an excellent clinician, an excellent psychotherapist, or psychopharmacologist. But if that's not written properly, if that doesn't come across in the manuscript, it's as if it hasn't been done, and your paper will probably be sent back to you, either saying, sorry, try again somewhere else, or rewrite this and please send it back, depending on the mood of the editor and the reviewer. So what are the common methodological errors? Before I tell you about the do's, what are the don'ts? What should you avoid when you're writing this section? First and foremost, if you're going to write a study design, if you're going to mention the very first line that I did a case control study or a cohort study, it has to match the objective. Secondly, the methods should be described precisely. Like I said, they should be objective, they should be precise. At the same time, nothing important should be omitted. The methods should be something that have rigor. If you're going to assess, we know that in psychiatry, we don't have a biological marker or, an objective measure of everything, but we should rely on what is most objective. If I ask a patient, are you depressed? He may or may not be willing to answer me. But if I take a rating scale and apply, and I count the score of all those 10 or 12 or 24 items, that is more objective than just asking a person whether they were depressed or not. Samples should be selected in such a way that there was no bias involved in sample selection. The sample size should be adequate to answer the research question. The statistical analysis should be appropriate to answer your objective or to test your hypothesis. And if there were any confounding factors involved, they should have been corrected for. So even if you find that there were errors in this at the time of writing up your manuscript for submission, try to make sure that they are corrected and addressed in the method section before you send it in for submission. I'll give you some examples, because sometimes when you talk about these things in the abstract, they don't make sense. But when you look at concrete examples, then you understand what is wrong. So an example of a poor study design would be if you write in your manuscript, this chart review was planned to examine the efficacy of clozapine for people who have schizophrenia and comorbid alcohol dependence. Now, you don't use a chart review to examine efficacy. You can use to comment on response or patient outcomes, but efficacy requires a clinical trial. You can't do it with a chart review. Vague description of methods. So if you write a sentence like, patients who were confirmed to have bipolar disorder after proper assessment were recruited, it will be sent back to you. Whereas if you write patients who were diagnosed with bipolar disorder as per ICD-11 criteria, based on 2 interviews with a psychiatrist or based on, a SCID or IPD or whatever, that's better. Lack of rigor, where you have an instrument that is validated and known to measure the outcome of interest or the variable of interest, you should use it. So if you say depression severity was assessed by asking patients to rate their sadness from 1 to 10, that may not cut much ice. But if you say we used the PHQ-9 or the Hamilton Depression Scale, they will automatically assume that you know your stuff and move on to the next item. Not controlling for confounders, again, is an important reason why papers get sent back to you. So if you are doing a study and your outcome is something and your intervention is something, you should be aware of all the other variables that might affect them. So for example, if you're going to test a drug for some condition, say disulfiram for alcohol dependence, you may want to know whether there is a caregiver who can monitor the treatment, whether they are concurrently receiving any other medication. And if you don't know that, or even if you know it, but you haven't mentioned it in your manuscript, it will look like you have missed out something. Is the sample selection biased? Sometimes I have come across papers where they say, we assess patients' attitude towards treatment, and only if they like the treatment, they were taken to the study. No. Obviously, patients have the right to refuse consent. But you cannot bias the sample by saying only those who like my medicine or only those who like my therapy are going to be taken. That creates a big bias from the word. Small sample size is again a common cause for rejection. So for example, if you're doing a genetic study, you know that you need a big sample size. So if you say I'm doing a gene association study, a single gene association study, and my sample was 45 subjects, they're not going to even, most journals will not look at it a second time. And inappropriate statistics. So for example, if you're going to compare the efficacy of 3 different doses on a drug, you have to use some test that can compare means or variances across 3 groups, like for example, an ANOVA. You cannot use Pearson's correlation, which is for examining bivariate correlations. You cannot use that test. It's not an appropriate test. Now, all these may sound a bit far-fetched to you, but I can assure you these are all examples that I have come across in real life. And, I'm just anonymizing them so that nobody feels bad about them. So now let's come to what we should do. We've talked about what we shouldn't do. Now let's talk about what we should do. So what should we include in each of those 6 sections that we talked about earlier? We start with study design, but before that, let's look at something concrete. Let's take a very basic kind of research question, something that we would do for an MD dissertation. So let's imagine that we are conducting a study to examine the relationship between current depressive symptoms and motivation to quit tobacco in men who are referred to a tobacco cessation clinic somewhere in your hospital or your medical college. So when you describe the study design, these are the 4 or 5 things that have to come. So study design in this case would be a cross-sectional observational study. On the other hand, if you are comparing people who came to the TCC with depressive disorder, without depressive disorder, would be a case control study. Then the setting, where was it conducted? What was the time frame? We often miss out this information. And if it was a clinical trial or a systematic review, you have to mention registration. Nowadays, most journals insist on that. And if it was a randomized clinical trial, you also have to give the details of blinding and allocation concealment. Ethical and related issues vary according to the type of paper. So obviously, if you're submitting a systematic review, there are no ethical issues involved. But for most original research, institutional review board and ethics committee approval has to be mentioned. Some journals may request the exact location of the ethics committee to be omitted because they want to maintain an anonymous, blinded peer review. If you did a study where consent was not required, for example, a chart review, or analyzing secondary data from a previous study, you have to clearly mention that. And if participants were provided with any compensation, that also has to be, that should also be mentioned, because that can also introduce a source of bias. Next, we come to the third point, which is the description of the study sample. So in this study, for example, if we were to specify inclusion criteria, we would say that we're taking male patients referred to our clinic and who score 5 or above on a screening scale for nicotine dependence. Exclusion criteria, obviously, we don't want people where there are too many other confounding variables. So we would exclude people with other substance use disorders, ongoing treatment, severe depression, active suicidal ideation, psychosis, who are medically unstable, who are cognitively not able to participate in the study, and so on. This is common sense, but we have to mention it. Informed consent and the process for it has to be documented. And if you are doing a study where the patient could not provide informed consent, you have to mention from whom it was taken. And the sampling process. In this study, it would have been consecutive sampling. You may have stratified random sampling or convenient sampling or other methods. You have to mention that. Materials, here it's a very simple observational study that we are talking about. So we would just be talking about rating scales. So what are the names of the scales? Are they self or clinician rated? How many items are there? What are the cutoff values? Are they validated and translated for use in that specific Indian language or local language? And some variables are not things that you can collect using a rating scale. For example, there's no rating scale to measure the patient's gender or number of years of tobacco use. So you would also have to mention what was on your data sheet, what demographic variables were collected, what clinical variables were collected. The study procedure is the part that tends to be the longest one, and how we can cut that down is something that I'll be talking about a little later. So we must first talk about where we recruited patients from, how many were screened, how many were eligible, how many refused to participate or declined to participate, how many were finally in. If anybody had to undergo training, let's say, for example, you're doing neuropsychological tests, or you're testing some new rating scale, and you want the investigator to undergo training, those details should also be mentioned. How was the data collected? And if there were any interventions or treatment outcomes that were measured, those have to be mentioned. In this study, it may not be may not be required, but in an interventional study, you would have to talk about it. And then the statistical analysis. At the very minimum, these 2 or 3 things have to be there. Details of sample size collection, details of any subject categorization or groups, treatment versus placebo, or this drug low dose versus high dose, or treatment plus placebo versus treatment plus some adjunctive treatment. And what were the statistical tests used? What descriptive statistics did you use? If you had a doubt whether your data was not normally distributed, what test did you use to assess whether the data followed a Gaussian distribution? What were the univariate, bivariate, and multivariate tests? I'm sure there will be a separate session on which talks in more depth about statistical analysis. So let's move on from there. Now, you may be asking yourself at this point, isn't this all a bit too complicated? How on earth do I remember all this? I might have forgotten something. How on earth do I remember that if it's an observational study, this need not be mentioned? If it's an interventional study, this has to be mentioned. If it's a systematic review, I have to register it there. Isn't it too complex? Well, yes, it is. So how do we make it a little simpler? So to move beyond these general recommendations that you can find in the literature and in textbooks and handbooks, now we've moved on to the era of checklists and guidelines. So I'm going to show you screenshots that I've taken from the web pages of 3 journals. I'm not going to name them. That's not the point of the exercise. But, in the beginning, you would find that journal articles would just give you descriptions like this. They would say, this is the word limit. You should have background, methods, results, conclusions, include this many tables. They would not give you much further information about what else is required. What should you put under the methods section? Later on, journals started becoming a little more specific. So they would say, if it's a randomized controlled trial, use the following guideline. Use flow diagram, etc. But that wouldn't be of much use to you if you are not writing a randomized control. If you were writing the study about motivation to quit tobacco that I described a few slides ago, this wouldn't help you. So now many journals give you a whole list of what guideline to use for which kind of study. If it is use this. If it is, a diagnostic accuracy study, use this. If it is an observational study, use this, and so on and so forth. So the point I'm trying to make is that, we are now in an era where many journals require adherence to specific guidelines and checklists when we write the methodology section. And if you don't do that, the paper will probably be sent back to you or, asked for, you will be asked to make extensive revisions. So this is a part of a broader trend in society. I don't know how many of you have read this book or heard of this book by Atul Gawande, who says that even if you're an expert, even if you're a genius, there are going to be things that you forget and things that you miss out just because you're tired or stressed or busy. And, the way to get around that, the way to make sure that you don't miss anything is to have a checklist. Now, we use checklists even in day-to-day life. How many of us use shopping lists when we go shopping? I'm sure we all do. That basically ensures that nothing essential is omitted because all of us can forget. Checklists by themselves do not guarantee that your paper is going to be accepted, but they do make sure that you would not have missed out anything important and that all those 6 domains, all those 6 key areas of the methodology section get covered one way or another. Now, where do we find these checklists? The good news is that, we don't just live in an era of checklists, we live in an era of open access. So most of these checklists and guidelines are available for free use. The place where they are all gathered together is a website known as the Equator Network. Equator is an acronym. It stands for Enhancing the Quality and Transparency of Outcomes in Health Research. It's an online library that contains all these guidelines for various kinds of health research. And it is available online at this website. You can all have a look there. Many of you must already be familiar with it. As of today, I just happened to check today, Equator contains 692 reporting guidelines, So are we back to the same situation that, it's too complex? We have too many guidelines, too many checklists. Well, not really, Of course, if you really want to go into Equator, with a fine-tooth comb or with a magnifying glass, you could find that they have checklists for everything. There are checklists for how to report spinal cord stimulation for spinal cord injury. There are checklists for how to report sham controls in acupuncture and acupressure trials. There are checklists for how to report research on children's footwear. Okay. There are checklists for animal research, for AI research, for large language models, for machine learning. You get the idea. But the good news is that you don't need to worry about most of these 692 checklists and guidelines most of the time. The majority of the work that we will be doing will fall into one or the other of these categories, and these are the commonly used checklists. And if you want to familiarize yourself with checklists, if you want to get into them and start looking at them, this is where you would want to start, Most dissertation work that we do is either observational or interventional. And so this checklist that is used, or the guideline that is used for observational research, is the STROBE guideline, which stands for Strengthening the Reporting of Observational Studies in Epidemiology. For randomized trials, the gold standard is the CONSORT guideline, which was most recently updated this year, which stands for Consolidated Standards of Reporting Trials. Those of you who were with us last year may remember that for systematic reviews, it's the PRISMA, Preferred Reporting Items for Systematic Reviews and Meta-Analysis. But if your meta-analysis is on observational studies rather than interventional studies, there's another, checklist and guideline called MOOS, Meta-Analysis of Observational Studies. If you're doing qualitative research, if you're, for example, trying to find out patient perceptions of a treatment or of, mental health care, and there's no quantitative data involved, then there's something called the COQ, Consolidated Criteria for Reporting Qualitative Research. Now, we even have guidelines for case reports, So even if you're writing a case report, patient was on duloxetine and developed seizures at a dose of 10 mg per day, and you want to write a case report, the editor will expect you to follow this guideline. So you have something called the CARE, Consensus-Based Clinical Case Reporting Guideline. And if you're doing a diagnostic or prognostic study, you're saying you want to study the implication of this variable for short-term treatment outcome, or the implication of this variable for prognosis in patients who are followed up for 1 year with this disorder, then there is something called the STAR-D. Now, this is where we psychiatrists get confused because STAR-D is also the name of a famous antidepressant trial, but this STAR-D is different. It stands for Essential Items for Reporting Diagnostic Accuracy, and it's basically for studies where you're trying to talk about either a diagnostic tool or predicting the outcome, giving prognostic, variables for a particular disorder. The Equator Network website doesn't just stop at collecting and organizing guidelines like a big library. It also gives you what is called a writing toolkit. So this guide, if you go and click on the Equator Network toolkits, it will give you a heading which says, which it's very optimistic. It says how to write a great research paper using reporting guidelines. And what it says there is, it will tell you which guideline is the best for your kind of study. And then it will give you sample articles, sample, papers, what errors are commonly made, what is an example of a good paper or a good methodology section. So it is very informative and very interesting to have a look at this. So let's have an example. Let's go back to the study we talked about and look at the Strobe checklist, because that was an observational study. So the Strobe checklist has items for everything: title, abstract, introduction, methods, results, discussion, etc. We're not going to talk about the other parts. We're only going to talk about methods. So what the Strobe checklist says is that when you're going to describe methods, when you're going to write the methodology section, this is the bare minimum that you have to do. First, mention the study design. Then describe the study setting, the time period, how long they were followed up. Then describe what were the study participants. Was it a cohort study, a case control study, a cross-sectional study? What were the inclusion and exclusion criteria? Where were the patients recruited from? And if it was a longitudinal component, if there was a longitudinal component, how long were they followed up for? Then define all the study variables. What are the variables of interest? What are the confounding variables? What are the so-called dependent and independent variables? If you're using a patients with a specific diagnosis or a specific disorder, mention the diagnostic criteria. For each variable that you're measuring, mention how it was measured. Data sources and measurements. So if you're measuring depression, don't just say we assessed all patients for depression. Mention which criteria or which rating scale or which screening instrument was used to assess depression. Then mention any efforts to address potential sources of bias. For example, did you use a stratified sampling technique so that you would get equal numbers of males and females? Or did you match cases and controls, to minimize this chance of bias? Describe how the sample size was calculated. We often forget when we write thesis, but we don't do it when we submit the paper. Explain how the variables were handled in the analysis. If you are doing subgroups, why did you pick those subgroups and how were they defined? Describe all the statistical tests, and if there was any missing data, like let's say you did a follow-up study and there were some patients who did not come for the follow-up, how was that missing data handled? And if there were a lot of outliers, say for example, most of your study subjects were 18 to 40, but there was one patient who was 65 years of age. Did you repeat the analysis omitting those odd cases or outliers to make sure that the result still holds good? Or was the result just a fluke because of one or two outliers? That's called a sensitivity analysis. So if you leave out the odd, the extreme, the dodgy cases, and then repeat the analysis, are you getting the same results and how are you going to do that? So as you can see, this maps very neatly to those 6 things that we talked about earlier. You have to talk about the study design and setting, the sample description and sampling technique, the study variables, the data sources, and how it was analyzed. You also have to mention the ethical issues and any compensation if it was applicable. So now, what you can do maybe after we disperse today is try it yourself. Take one of your thesis protocols, or if you have moved on from that area, that stage of your career, take one of your students' thesis protocols and see if you were to write this as a paper, what information would go under each of those items of the Strobe checklist for methodology. For example, coming back to the study that we talked about, if your variables of interest were say depression or sleep quality or motivation, what would you write under data sources and measurement? You would write what the variable was, what the instrument was used, which was used to measure it. Is that instrument validated? How many items does it have? Is it self-rated or clinician rated? What are the cutoff values? What is the, reliability and validity of that instrument based on previous studies, and so on. Another important component of the checklist era methodology is the flow diagram. Basically, what a flow diagram does is it tells you how the subjects were recruited into the study, how many were excluded, if it was a longitudinal study, how many were lost to follow-up, and finally, how much data was available for analysis. So a good flow diagram provides invaluable information about the credibility and validity of a study. Whereas if this is missing, people will think that you're trying to hide something, I'm sorry to say that nowadays, both editors and reviewers have become a little paranoid, a little suspicious about research because there is so much bogus research being submitted or, so much AI-generated research. And so the first thing they will do is they will check and see whether you have this checklist in place. Suppose your journal says, we don't want this diagram as part of the main methodology section. They will still ask you to submit it as supplementary material. So don't forget that. Make sure that you have this flow diagram. If the word limits and space limits of the journal allow you to include it in the main methodology section, please include it. If not, upload it as a supplementary material, which is for you. Coming to the very last bit, some other general tips that I have gathered through reading other papers on how to write a methodology section are these. First, one thing that I came across in two papers, one written by Indian authors, one written by an author from the United States, is it is better to include more than less detail. Reviewers and editors may ask you to remove unnecessary details, but they will still be impressed with the fact that you've included. Whereas if you omit key information, they will think that you've forgotten to do something or there was something wrong with your study protocol, even if what you actually did was perfect. If in doubt about statistics, there's nothing wrong with discussing with an expert. I can honestly tell you that I know statistics only up to a certain point. If I had to do, for example, survival analysis or sensitivity analysis, I would definitely talk with a statistician before writing my statistics section in the methodology. This could either be a person who's actually a trained statistician, or it could be a researcher who's more experienced than you. Don't forget to mention these things like review board approval, consent, compensation related issues, and registration if and when they are applicable. When the methodology of your study is a bit innovative, let's say, for example, you're describing a new TMS protocol or a new RTMS protocol for the treatment of depression. Just doing a flow diagram may not tell the reviewer what this protocol is and how it is different from the usual RTMS that patients already get. So you may want to have a diagram which shows, how many pulses are applied, to which regions it is applied, and, how many sessions there are per week, what was done in the intervention group, what was done in the control group, so that they understand at a glance by just looking at the diagram what was new about the intervention in your study. And finally, when you're writing the method section, use a uniform voice. Use either the active or the passive voice. If you're going to use the active voice and you're going to say, we recruited so many patients, afterwards, don't write patients were interviewed. That's the passive voice. Don't switch from one to the other. If you're going to start with the passive voice and say patients were recruited from the hospital from this date to this date, don't later on say we applied the Hamilton Depression Rating Scale. Make sure that the two are consistent. So that brings me to the end of this very brief overview of how to write a methodology section and how the field has moved on from not being taught about it to having just some general guidelines, review papers, to actually having checklists and libraries and toolkits that you can consult. So we are fortunate to have everything at our fingertips, but we should avoid an information overload and pick what suits us best. So the following are a few homework assignments that you can, choose to do. It's purely for your own interest. There are no marks assigned or there are no internal assessments that are going to happen. One thing that you could do is go through a research project or dissertation that you were involved in and try to construct. I'm sorry. Try to see if you can construct. If you could construct a flow diagram, go back to a dissertation that you wrote. You may or may not have put a flow diagram in it. Try to write that flow diagram in strobe format. You will gain a lot of experience just by doing that simple exercise. Another thing you can do is you can put on my glasses. You can put on the peer reviewer's glasses. Pick up a recent issue of your favorite journal. Pick any article, preferably an original research paper because review articles are a bit different. First, look at the 6 headings, the study design and settings, ethics and related issues, sample description, procedures, data analysis, and those 6 things, and see whether all of them were included in that paper, whether the paper used a reporting guideline, and if none was used, what would you use? And if you were given the chance to revise this paper, of course, it's already printed, you are not going to do it, but if in an ideal world, in a dream world, you got the chance to revise this paper, what changes would you make based on what we have just talked about and what we have just learned? So the following is some further reading. If anyone wants copies of these 3 articles that I mentioned here, I can send them to you or I can share them in the chat. The Equator Network website and toolkit is, of course, open access. So I would invite all of you to have a look at it after we wind up for today, because you will get a lot of insight from there by just doing it yourself rather than just listening to what I have to say. So I'll stop here, Thank you very much for listening to me till now. And I hope that it was informative. I'd be glad to take any questions or any queries or, even corrections that you have.
That was a wonderful session, Dr. Ravi, sir. I think we all are mesmerized with what you have presented and we all have gotten so many answers for our queries. This is one thing I wanted to ask about. Dr. Rao sir is also there with us. Good evening, sir.
Sorry, I got little delayed, and I'm more than happy that again engine has started with new ideas, new topics, and new learning for everybody. All the best.
Thank you, sir.
Mm.
Thank you for joining, sir, with your
Thank you,
busy
sir.
schedule.
I'm extremely sorry I couldn't join at that particular minute, and I congratulate everybody who is part of this wonderful programs that has been scheduled. Good.
Thank you, sir. Dr. Vijay sir is the brain behind all of it. I think Vijay sir
I'm very much here. Yeah.
Yes, sir.
I think sir has
My
posted
mobile
a
was not there
question.
at that minute. I was searching. That's why I couldn't join Harish. Vijay Harbishatar.
Yes.
So, sir, as I was continuing with my question, there are a lot of things like many people are more worried and scared when it comes to drug trial. With the DGC approval and everything. Can you throw some light on that particular aspect? Because they've covered everything, but I think this was somehow we just need a little bit more light on this topic, if it's possible, sir.
Sure, ma'am. Of course, the conduct of a good clinical trial, a drug trial, is a very vast topic in itself. But to just put a few key points across. One would be that now most journals wanted to be presented in terms of the consort guidelines. So, probably the first step to start would be to try and adhere to that. And even before you start the protocol or even before you start designing the drug trial, to have a look at that, because you know what the expectations of external reviewers or editors or even people who are going to give you funding, because most of them are also now in this mode of looking at consort or looking at similar guidelines to see what needs to be done. The second thing is to look at what the regulatory authorities in our countries, for example, before you try a drug, we need to know whether it is DCGI approved for that indication. If it is not approved, there's a process for obtaining approval, which varies depending on what the drug is and what its exact labeling or schedule is. You would need to register your protocol on CTRI. Of course, nowadays CTRI registration is not is being done for a lot of studies. It's no longer as rare as it was before, so you would have to do that. But I think it all boils down to, before you even start the study, apart from looking at consort, looking at regulatory guidelines, to have a clear idea of what is it that we are going to test. What is our study population? What is the outcome that we are looking at? For example, if we're targeting negative symptoms of schizophrenia, we have to target only that. Or if we're targeting, let's say, obsessive compulsive disorder symptoms, we would have to have some reliable way of measuring them pre and post. Then we would have to decide whether we want to do a placebo-controlled trial or an active comparator trial. Placebo-controlled trials are justified where we don't have a known gold standard, or where there is still some uncertainty about whether there is a gold standard, or it's sometimes the term equipoise is used to refer to this. But what it amounts to is, when you are absolutely sure that some treatment is very effective and life-saving, you can't deny it to a patient. But when there is some doubt, let's take the scenario that I mentioned of negative symptoms. There is no gold standard treatment for negative symptoms. Even though there may be positive trials for clozapine or amisulpride or whatever, we don't recommend any one of them, or nobody in the field says that is the gold standard. So then you are justified in doing it. Then you would have to define your sample clearly. And when defining the sample, you would have to strike a balance between a very, very specific sample, where you would, eliminate all confounders and you would, not have any noise when doing the statistical analysis. But at the same time, recruiting such a sample means that you cannot really generalize from the results. So if you put in too many exclusion criteria, questions may be raised about whether your study can apply to another setting or to a routine clinical setting. Whereas if you make it too broad and very naturalistic, you do something like, for example, the KT trial, then the opposite set of questions would arise that, there are so many confounding factors that so the idea is to try and strike a balance between the two. Then the intervention, you would probably have to be guided by the prior literature. If there's no guidance from the prior literature, you may have to try either one standard dose, or you would have to go for one low dose and one high dose. That's another thing that you could do. You would want to decide whether you want the person completely off treatment or whether you want them to also receive treatment as usual. If it's, for example, an augmenting agent or an adjunctive treatment, they continue with treatment as usual. But if it's a treatment that is for primary efficacy, you would probably want them to be off drugs or drug naive, and give the washout period based on what the expected half-life of the standard drugs. Like if an antipsychotic is going to be used, we would want to allow that many half-lives to elapse before the patient is enrolled into the study. The other thing that becomes very important is nowadays many journals insist that before doing a trial, there should be some involvement of the stakeholders, So it's not just that, you are doing it out of your own interest, but, is there some benefit, tangible benefit to the patients from this? Is there a felt need from patients or caregivers that the study is going to benefit them? Are the existing interventions, economically not very viable, and are you trying to provide a cost-effective alternative or a lower cost alternative? So that's another thing that, in fact, that's one of the very first items that comes in when you look at the consort guideline. Were other stakeholders consulted when this research was done? Who else's opinion was taken when designing this protocol? And the data analysis, I think the key things that come up here are, how do you handle dropouts? That becomes a very important issue because sometimes it looks if we do not handle dropouts adequately, either if we take a very, optimistic approach and say, okay, we're not going to look at the data, or, there are only very few dropouts, that generally leads to an outright rejection. There are various statistical procedures for dealing with dropouts or people who discontinued or whatever. And that, again, is where the statistician comes in because they would be best placed to advise you on that. Another important thing to remember is nowadays, most people who review or who consider interventional trials for publication will not be happy if you only talk about efficacy. They will also want you to have at least some data on tolerability or acceptability. So that also has to be there, even if it's only the secondary outcome measure or even if it's not the primary outcome, that would have to figure in some.
Okay. Thank you, sir. So there are some questions which are there. Dr. Saratha wants to ask, what would be an appropriate sample size to ensure that our study findings are representative and relevant in relation to the estimated prevalence?
I think that's a very good question, Dr. Saritha. So the question is, what would be an appropriate sample size? So when we calculate a sample size, we generally do it in a different way. What we do is, if it's an epidemiological study, if we have some kind of rough estimate of the prevalence of that particular condition or disorder, then there's a formula for calculating. But if our intention is to say assess the efficacy of a treatment or the estimated difference in something between two or more groups, then we need to either base ourselves on previous literature in the area. Even if we don't have a study that is exactly like this, you could take something that is similar to it. So let's say, for example, we know that some treatment is effective for reducing negative symptoms. And in the trial, which, found that result, the mean difference in that measure of negative symptoms was this many points or this many standard units. Then once you know that value and once you know the standard deviations in the two groups, there is software that can give you that value. But I think what you're asking is something beyond that. Probably what you're asking is, would this sample size be adequate to generalize these results to the broader community or the broader population? And that is a very good question for which there is no single answer, but the answer would be that you have to have as large a sample as possible. And not just as large, as representative is also what is very important. If you have a large sample size, but you're taking only male patients, obviously you cannot generalize that result to female patients, even if your sample size was 1 billion. But if you have included, say 100 or 200 or 300 subjects, but you've made sure that you have a fairly even distribution of young and old, men and women, all those things are sort of adjusted, then it's likely that you can generalize. So it's not just a question of sample size will help you to determine that you're not getting either false positives or false negatives. But when it comes to making it representative and relevant, it's not just a question of how big your sample is, though that does matter. It's also a question of how representative it is, where you would have to bring in things like stratification, block randomization, things like that.
I hope it answers. Dr. Vijay sir wants, sir, is that a comment on type 1 and type 2 error?
Yeah, that's what Dr. Ravi was mentioning just now.
Yes.
That's what I meant. I have another question previously I've written. So.
I've seen that, sir.
Yes.
So I think sir's question is, one is many thesis protocols mention purposive sampling. We purposively select patients who fulfill only these criteria and thesis gets completed. But when we submit, we mention that, they say that this cannot be generalized. This is a limitation of the study and all that. Well, one way of looking at it is that sometimes journal editors take an open-minded view, and if you acknowledge that as a limitation of your study, they will still consider it if your other findings are good enough and your methodology is sound enough. But another way to get around this problem is to simply mention that you've used convenience, or that you have used consecutive sampling, and that this many do not fulfill the criteria and were filtered out, which is where, the flow diagram helps you to convince them that you have actually done this step and you have not just pretended to do. So, one way of getting around this is to, use the flow diagram to supplement your sampling method and to mention that these many were excluded. Also to collect data on those who were excluded, not just the number of those excluded, but rough data about their age, sex, income and all that, so that you can later on include a statement that those who were excluded do not differ significantly from those who were included in terms of basic demographic variables, which would again be a point strongly in favor of your study being something that can be generalized, So it's very important that when you exclude patients from the study, don't get irritated with them and not collect any further data on them. At least make sure that you have basic demographic information, basic clinical information on them, so that if this question arises, you can present a table or a supplementary table or a supplementary analysis which says we compared those who were excluded with those who were included, and they differed or did not differ on these demographic or clinical variables. And hence, this is what I can comment about, whether it's of good generalizability or limited generalizability. So I think the message here is not really to worry too much about the sampling, but to collect data on those who were excluded or who didn't participate or who dropped out. I have often found that is a question that gets asked very often, when this issue comes up.
So many times even as students, we often get dropout. We're not able to follow up. But just to maintain the exact sample size, we sometimes fail to write and talk about the dropouts. So is it something that it's a good practice or a bad practice, sir?
One of the problems is that in a country like ours, with a large population and a lot of logistic issues, you do get high dropout rates. But even so, I have seen papers published from even a very, premier institute in our country, where they openly acknowledged that there was a 30 to 40% dropout rate in a follow-up study of alcohol dependence. The paper got published in an index journal. So being honest and upfront at the beginning is always better than trying to conceal it and then getting caught by an eagle-eyed statistician or an eagle-eyed reviewer later. Another way of getting around it is to, as I said, to at least have the baseline data for them. Because then there are statistical techniques that will help you to handle dropouts. You can either, you can do the intent to treat analysis. So there are even more conservative methods than intent to treat analysis. But once you have the baseline data, there are always ways of at least making sure that something was done to handle the dropouts.
Noted, sir. There's another question from Dr. Kulkarni. He's appreciating your session, sir, and he wants to know, in case we have data that needs to be presented in 2 or say sometimes in 3 parts, then how to manage method section in second or third part of the study manuscript after first part is published, in addition to citing and mentioning how second part is relevant, different from first part of published study to avoid the salami. So is it okay to mention study methods are detailed in our earlier study and mentioning details relevant to second part of the study, or do we need to paraphrase and write again? Similarly, issues to be detected through. So it's about the part publications, which we sometimes do from one manuscript, and how to change or write the methodology. That is what he is trying to ask, sir.
Yes, ma'am. I think this is another excellent question, sir. I think to come to the first part, suppose you have data that has to be presented in 2 or 3 parts. Let's say you're going to present efficacy mainly, then safety, and then long-term outcomes in 3 different papers. Short-term safety and long-term outcomes. Then what is useful is one approach that is being taken increasingly nowadays is to write the methodology paper itself as a separate paper. There are now many journals that accept only study protocols or only the methodology as a separate paper in itself. And there is even a guideline as to how to write pure methodology papers or pure protocol papers. I didn't talk about it because that would be sort of confusing the issue, but we reached a point where we not only have journals that encourage the submission of protocols per se, but that also there are also guidelines that you can find on Equator as to how to write a protocol and submit it for publication even before the results come. So if your study is big enough or large enough or multicentric, or it's a big randomized control trial, that's the simplest solution. Do that, and then all your subsequent results papers refer back to it. They refer back and say, the protocol has been detailed in so-and-so, or has been detailed in this paper. Another way of doing it is what you have mentioned, sir, which is also equally valid, which I've also seen, where the first paper, the one that mentions the primary outcome or the main outcome of the study, gives a detailed description of the methodology, and the subsequent papers which focus more on subgroup analysis or further follow-ups or long-term follow-ups, they say refer back to the first part of the study. To give you an example, I once came across a study of post-traumatic stress disorder in people from a particular country who were held as prisoners of war. The first study followed them up after 14 years and gave a very long description of the methodology. The second paper followed them up after 20 years and said refer to paper 1. The third paper said, followed them up after 28 years and said, refer to paper 1. And all these 3 were published, accepted in 3 good, index journals. So as long as you have a clear reference to it, and it's not that you're just trying to get, publish the same paper in different guises elsewhere, I don't think editors will have a problem with it as long as you tell them that it's described in detail. So the 2 workarounds here are, one is publish the protocol initially and then start publishing the results one after the other, or publish everything in the first paper, the one with the first study outcome, and then make all the other papers just refer back.
Exactly said, sir. Another question from Dr. Ravindra Manoli, sir, is the duration and year of study is not mentioned in many papers. So which is a glaring error during paper review. So what should be the approximate proportion of methodology section in manuscript when compared to introduction result discussion? So there are 2 separate questions from sir.
Thank you, sir. I think both of those are very important questions. If we come to the first one, why do we not mention the duration and year of study? But sometimes that detail is removed, because they want to maintain anonymity or they want to maintain blinding. But most of the time, it's just something that we forget to do. So as peer reviewers or as editors, we should ask them to include that information, because sometimes if a result is being published many years after the data is being, after the study has been done, then it raises some suspicions. Why are you writing a paper on something that was done 10 years ago, or 12 years ago? And are you torturing the data to make it confess? So it's very important that we get into the habit not just of publishing, what we have done, within a relatively short time frame, but even if you can't, to clearly mention when this was done, when the data was collected, and when the data analysis was done. Sometimes it may also help. Supposing your paper is not getting published, it's getting rejected by multiple journals, but you want to avoid this issue of people saying, why did you write it later? You can submit your paper as a preprint sum, so that later on, if when somebody asks you, why are you writing a paper in 2025 about data that was collected in 2020, you can say that the study was done and submitted as a preprint there, and you can refer back to it. That's one way of doing it. The second question, what should be the approximate proportion of methodology section in a manuscript when compared to everything? Well, I think that varies a lot according to the journal policy. Some journals insist on a very long introduction, a very long discussion section. Others want it to be very succinct and have, very strict limits that, only 3 tables, only 2 figures, only this many words and all that. So I think it just varies according to the journal. But what is important more than the word count is whether all those key points that are in the stroke checklist or consort checklist or, the guidelines that, we talked about earlier, whether those are all covered, as long as those are all covered, the exact word count isn't. Think of it as something like a newspaper report. When a person is writing about a news story, it's not the exact length that necessarily matters. It's whether all the key items about that event or that disaster or that incident have been reported properly by the journalist. The person writes a lot of pages, but writes, my opinion was this, or I spoke to somebody who was living in the next road and he said this. That may not carry much value. You can get away with that as a journalist, but not as a researcher. So it's not the actual number of words that really matters. It's whether all those 6 areas, all the items on the checklist have been touched upon and covered at least in 1 or 2 lines. Probably even more than
that. Rightly said, sir. How you initially mentioned credible and replicability, and it should be precise in answering our right questions. So Dr. Muskan Jaiswal, she wants to ask the question. She's a PG first year. So what is the most common methodological mistakes we PG students make in their thesis, and how can it be avoided early in the research process that creates a problem later when we are writing the research paper?
I think this is an excellent question. You should really appreciate that a first-year resident is coming up with a question as, insightful as this. Because it's very true that prevention is better than cure. If you do a flawed study and somehow it gets approved and then you try to write it, you're just going to encounter a lot of rejections and a lot of discouragement. So it is true that we should be aware of the most common methodological mistakes. Now, fortunately or unfortunately, there are even people who have written papers about what are the common, methodological errors or what are the common reasons why people do not, accept a paper. And one of the things that you can see there is, if you were to just look at these, and I'm just going to read them out from one of the references that I have. Common reasons why the papers are not of good quality or why a study is not of good quality is, one, it did not address an important scientific issue. For example, if your paper is on the values of liver function tests in patients with depression, that's not very important unless your patients are on some hepatotoxic drug or they have comorbid viral hepatitis. If the study is, not original, replicating a previous study is okay, but then you must say explicitly that you're going to replicate the previous study. The study must test the hypothesis. So if your hypothesis is, for example, that sleep quality is associated with depression in patients with bipolar disorder, you should have some test or some scale or some method to assess sleep quality, to assess depressive symptoms, to recruit patients with bipolar disorder, not with some other disorder, and to test the association between those two. The study design was inappropriate. So if you're testing the efficacy of a treatment, it's an interventional study or a clinical trial. If you're trying to establish things like prevalence or, frequency or correlations, it's an observational study. Deviations from the protocol also become an issue. So don't be overambitious. At the same time, don't be too, small scale or unoriginal. If you say, I'm going to do a study on 20 patients, you may complete it, but you may not get it published elsewhere. If you say, I'm going to do a study on 500 patients, but you end up recruiting only 100 and you write that in your paper, that also looks bad. So the guide must help the candidate to fine tune and make sure that the study is feasible, but at the same time of good scientific quality. And the statistical analysis has to be good. That's often a reason why, studies get into trouble. I had this problem as an MD resident, where I did some correlation analysis where actually what was needed was a non-parametric test. And I had to make that correction just before the thesis was sent for printing. So, don't be like me. Don't do that, So it's always useful to talk to a statistician beforehand and, to find out what tests are going to be useful to analyze your data. And when you write up your conclusions or when you write up, the discussion section of your paper, it's very important to make sure that it matches what your study actually found. Don't include a lot of, your own speculations or your own theories and all that, because that doesn't really have much validity or much replicability. So these are the common errors that we make. Either the study design is not appropriate, or the study didn't actually test the hypothesis, or, it was something, it was just literally copying another study without saying that you're actually trying to replicate or you're trying to extend it, or the sample was so large that you couldn't beat it and then you had to compromise on it later, or the sample was so small, it was just that you wanted to finish some work and be done with it. So it's a question of navigating between, two poles. On the one pole is a thesis that gets completed on time. On the other pole is a thesis that you can publish somewhere. You have to sort of find the middle terrain or the middle ground between the two.
Lovely explanation, sir. I hope Dr. Muskan got the answer. So coming towards the last question, Dr. Somesh Anand Patan wants to know, how should a researcher address the unavailability of clinician-rated scales in local language when describing their methodology?
I think that's a very important question, because we often conduct our research in patients who are not fluent in English, and we have to have a scale that is adapted to a local language. Now, sometimes if the instrument is something that is very well established and validated, they will have a website, or the author of the scale will have a website, or the copyright holder will have a website which tells you which languages that scale is available. And if it's already there mentioned, then you can mention the scale has already been validated and adapted, and details are available at this website. On the other hand, if it has not been done, that doesn't mean that you need to take it as a discouragement. You can, in fact, even take it as an opportunity and try to translate the instrument yourself, provided that you have the permission of the author or the copyright holder. Or if that's not possible, you can always try to select an alternative instrument. Another way of doing it is to just search for studies from your particular country or your particular area using that scale. So for example, supposing the scale is the hospital anxiety and depression scale, search for hospital anxiety and depression scale bar HADS or terms that are similar to that, and Then add the additional terms of, India or Indian or, Tamil Nadu or Karnataka or Madhya Pradesh or wherever you want to add it. Or, or you add the language name. Sometimes that's even better. Add Hindi or add Tamil or add Kannada or add Bengali or Urdu or whichever you would like to add. And then you will find, whether there was somebody who's actually done it before. But that's, that's a bit of a laborious method. You'll have to go through a lot of search engines and make sure that you didn't miss anything. The simplest way is to just contact the person who's developed the scale, or to look at their website, or to look at the website of the copyright holder. You would find information on whether there is an adaptation of it. For example, if you look at the website for the Addenbrookes, the details on the Addenbrookes cognitive assessment for patients with dementia or cognitive disorders, you would find that there is a valid version in such and such language. There is a valid Hindi version, for example, and then you wouldn't have to worry about it. You would just mention that this instrument is already validated in Hindi, and we are going to use that version, or we have obtained permission to use that.
Thank you, sir. So I have two adjoining questions to this. One is, so when I was doing my dissertation, it was on disruptive mood dysregulation disorder. I think it was a very difficult thing with a 500 sample size. I remember having a very difficult time in arranging for fields and all. So we were trying to do a screening, self-made screening tool. So that time we were told, like, if you make a self-made screening tool and you get it attested with 3 of the psychiatrists, and then you can use it as a screening screening method, and you can rule out others which are other kids which are not there in your study. So how much reliable that is? And second thing, many a times, lot of people write, and while they were taking the history, so they have made a self-made performer. So these two things, the self-made screening tool or self-made some scales which we make and get attested, how valid are they? And your comments on that, sir.
I think that's a very important question, ma'am. Basically, the question is, when you don't have an instrument, or when it's difficult to get a copyrighted instrument, how do we go about developing our own instrument? But the actual process of instrument development is quite a laborious one, because first you have to, select the items either based on expert opinion or based on focus group discussions with patients and their caregivers. Then you have to select all the items. Then, develop an instrument that captures all of them. Then do a factor analysis and see if you can boil it down to a smaller number of items. Like, say, if your initial instrument had 50 items, but many of those items load on one single factor, then all those 3 can be captured by one question. Then you take that instrument with the minimum number of items. After your factor analysis, you do a pilot study. You assess things like reliability, inter-rater reliability, test and retest reliability. You test face validity by correlating it with other measures of either the same disorder or other disorders. So I'll give you an example. For example, when we were trying to validate the fear of COVID-19 scale in one of our residents' dissertation, there is no gold standard instrument for measuring fear of COVID-19. But we know that fear of COVID-19 has to correlate with anxiety, but it cannot correlate very strongly with it. If it correlates very strongly with it, your instrument is just measuring anxiety. It's not measuring fear of COVID-19. So what we did is we took a scale that generally measured anxiety. I think it was GAD-7 or HAM-A or something like that. We looked at the correlation between the two, and we found that it was a positive but a modest correlation, somewhere in the range of 0.4 to 0.6, which again gives you some amount of face validity. It gives you an idea that the instrument is measuring anxiety, but it's not measuring general anxiety. It's measuring anxiety that is specific to something. Now, often it happens that we cannot go through this rigorous process during the time frame that is available for an MD dissertation. So then what is often done is to obtain expert opinion or expert consensus. There is nothing wrong with that. There's absolutely nothing against that. And in fact, even here it is commonly practiced that, for example, if a nursing student has to do a project in a short time frame and they have to develop their own questionnaire, they get it validated by one person from our department, one person from a psychiatry department elsewhere in the state, one person from somewhere else in India, from a different state or a different part of the country. And that generally gets accepted. And some of them have even got those papers published. So that is perfectly okay if it's just a questionnaire. If you're developing like a rating scale, then you may have a bit more of a problem. But if it's just a questionnaire, you're just trying to capture all the key symptoms or, items of a particular disorder, or you're just trying to capture basic, demographic details or risk factors or whatever, then validation by expert opinion is absolutely okay. The other process that I described of, focus group discussion, factor analysis, a pilot study, etc., is more when you are trying to develop your own rating scale. If you're not trying to do that, then expert opinion is still fine.
Okay, sir. Because we remember my teacher has also joined, Dr. Suprakash Chaudhary, sir. professor and like a lot of papers. So sir has guided us. We have developed a lot of translational skills also when we were doing our my colleagues and we all were doing our skills. So thank you, sir, for answering that question. Now, if there are any other comments from anybody, please mention in the chat box. If not, I will be handing over the session to Dr. Vijay, sir. And thank you, Dr. Ravi, sir, for such an incredible session. We all have learned a lot and we have a lot of things to take home and learn and do our homework as well.
Thank you, ma'am.
And I'm really grateful. And I'm really thankful to Dr. Apurva and Dr. Ravi Shettar, sir, for including me in this session and making me a part of this incredible journey. I'm really grateful to you, sir. Handing over the session. Thank you.
Ravi, it was very useful learning. Apurva, you can
Yes,
take
sir.
over.
Yes, sir. So thank you so much, sir, for the informative session. A perfect benchmark beginning of for our online manuscript writing series. Methodology truly is the first step to even begin understanding research. Thank you, Dr. Samiksha, for moderating the session so smoothly and giving a kickstart for Wednesday Scholarly. Thank you all the participants for attending the session and actively asking questions. I now request Dr. Narayan Mutalik, Honorary Secretary, IPS Karnataka Chapter, to kindly say a few words of encouragement and guidance for subsequent sessions.
Dr. Narayan, just 1 minute. I would just like to share with you that I've uploaded 3 of the articles that I used to prepare this presentation. You can have a look at them as and when time permits. They are all, available in, or, either as open access or, if you have an institutional subscription. But I'm sharing them here so that we don't have to go hunting for them. They're always useful if you want to go back to this and refer and learn a little more about this topic.
Thank you, sir. Yes, sir.
Thank you very much, sir.
Thanks.
It was very elaborate and thought-provoking lecture by my teacher. Dr. Ravi Philip was my senior assistant, and we have learned a lot under his guidance. And he opened our webinar series. And I wish all the best to the subsequent sessions. Hope under the leadership of Dr. Vijay B. Harbishatta, sir, our journal will go into new heights. So all the best to Dr. Vijay Harbishatta, and thank you.
Thank you, sir. I now request Dr. Vijay Harbishatta, Honorary Editor for Journal of Psychiatric Spectrum, IPS-KC, the person behind the online academic series, to please share some thoughts.
I join already. Several people have commented. I join everyone in thanking Dr. Ravi Philip. Always something interesting. I was, like I mentioned in the beginning itself, that I was curious how is he going to prepare and how is he going to present, and he made things easier. He's one of the best teachers we have, and I'm glad he's also our chief advisor for our journal, and he's a go-to man when we are in trouble, when we are in difficulty. This is a very good start. We need to have a good opening batsman, opening partnership. So Dr. Samiksha has been outstanding. She's very enthusiastic, and I thought she would be the best person for this. Yeah, in the end, she agreed, and it all went very well. So subsequent sessions, we have a webinar on introduction next week by Dr. Shaji. And then following that, we have results and tables, how to prepare results and tables by Dr. Rajkumar Vipeta, Editor-in-Chief of the South Zone Journal, which is Indian Journal of Psychological Medicine. So these are the next, few webinars. So do not miss. At the end of these sessions, I'm sure writing a paper, either from your data, what you have from your thesis or whatever you have data, it should become easier, I would say. Not easy, easier. Okay. With that, I hand over back to Dr. Apurva and Dr. Murali later. Thanks.
Okay. Ravindra sir, any final comments from your side?
Yes. Thank you, Ravi sir, for the wonderful session. Also,
Thank you, sir.
Dr. Samiksha has joined our journal as a resource person, so she will be an asset for us. We had a glimpse of her skills also. And no doubt, Ravi sir, it's always a pleasure to listen to Ravi sir. And in addition to what Vijay sir has said, this has been in the pipeline in the last 2 years. We are contemplating to have in-person sessions of how to write a manuscript. But we thought at least we'll begin with this as a webinar series. Then down the lane, if everything materializes, we may think of considering a hands-on session of these also. So I request all the audience who have participated today, um, please continue attending. Also encourage early career psychiatrists and your resident to attend these sessions, because some more announcement of hands-on workshops also. Thank you all for participating. Over to you, Dr. Apurva.
Okay, thank you so much, sir. And as rightly said by everyone, this is probably the need of the hour kind of online series which we require for writing our manuscripts. So once again, thank you, Dr. Ravi, Dr. Samiksha, and all the attendees for today's session. I think we can now close today's session and see you all next week with the newer topic as told by Dr. Vijay. So thank you all again, and good night.
Good night.
Good night. Thank you.
Thank you.